Well, hi, everyone, and
Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
welcome. I'm Dr. Eileen Scully, an Associate Professor of Medicine at Johns Hopkins University, and welcome to Clinical Clips from CROI 2025. We're episode 2 of 4. So today, we'll start off by talking about some studies in the prevention arm of what we do in HIV. So abstract 163 was from Dr. Hyman Scott, looking at the high effectiveness and sustained effectiveness of doxy-PEP for STI prevention after a clinical implementation. Prior to the intervention, those who opted to start doxy-PEP had a substantially higher risk of STIs, and after initiation of doxy, that rate dropped to that of the non-PEP users. This study provides pretty strong support for the efficacy of this intervention in decreasing STI incidence, and while representative of a population of MSM, the protocolized implementation is one aspect that could be used across different study populations. In abstract 164, Dr. Michael Barry presented information about the doxy-PEP continuum. So in this study, they sought to identify what the barriers were to initiation of PEP, looking across the different moments at which doxy-PEP is either considered or initiated. They analyzed data from more than 6,000 individuals at a sexual health center in the Castro in San Francisco. This clinical site accounted for between 12 and 16% of reportable STI data in San Francisco, highlighting that this was an important population for STI interventions. So of patients with an indication for doxy-PEP, about 59% received a prescription, 61% reported actually receiving a script and taking medication, and 61% of them had high adherence. So at about each step, there was about 60% continuation through the continuum, with only about 22% of all the individuals with an indication for doxy-PEP maintaining high adherence. So factors that were linked to dropout at various stages along the way included younger age, Black or African American race, unstable housing, and being a person living with HIV. So these data can be viewed with some hope. Despite this relatively low penetrance, doxy-PEP has still been highly effective. And also in identifying the specific social determinants of health, it allows us to think about interventions that might specifically be points to improve uptake of this highly effective intervention. Next, we'll shift gears a little bit and talk about post-exposure prophylaxis in cisgender women in abstract 157. So optimization of pre-exposure prophylaxis for cisgender women at risk of HIV acquisition has remained an important challenge. And there are differences in tissue penetration of these agents to mucosal sites, limiting our ability to extrapolate from studies in men who have sex with men to cisgender women to determine whether there will be protective efficacy. In this study, the authors used a modeling approach to simulate multiple different types of dosing strategies for standard episodic pre-exposure prophylaxis using the 2-1-1 dosing that's used in episodic PrEP in MSM, and played around with increasing pill counts or extending the duration over which these medications would be taken. Using these simulations, the authors concluded that they could achieve 85% protection at 5 days after a sexual encounter with the standard 2-1-1 dosing strategy, and could increase that protective efficacy by between 8 and 15% with the same number of pills spread out over 4 days. As a primary barrier to PrEP efficacy in cisgender women is adherence, optimizing this type of on-demand strategy may be an important part of improving the utility of these interventions. Okay, so now let's dive into some new data on novel antiretroviral strategies and agents. So first, there's abstract 151. This was a study of the efficacy and safety of the combination of lenacapavir and 2 broadly neutralizing antibodies, which I will refer to as TAB and ZAB, in a phase 2 trial to assess whether or not this would be an efficacious strategy for treatment of HIV. Here in the phase 2 trial, they compared the efficacy of switching to the 2 antibody plus lenacapavir combination versus continuing on oral ART. As a reminder, the TAB antibody targets the CD4 binding site on GP120, and ZAB targets the V3 glycan loop on the HIV envelope. They enrolled 53 participants to receive the experimental treatment and 27 controls. And at week 26, they had one participant who had an HIV viral load greater than 50 in the experimental arm and none in the controls. There was emergence of resistance of a lenacapavir resistance mutation in that individual. And there was also a significant rate of anti-drug antibody formation, or ADA positivity. This is a key potential limitation to the use of this type of therapeutic, but in this study did not affect the drug pharmacokinetic profiles. So overall, the study did show some favorable aspects of the PK profiles of these agents, but given the emergence of resistance in that one individual, it does raise questions about the durability of the response, and there are still challenges in confirming antibody susceptibility prior to starting treatment. There were two other presentations highlighting novel agents. Abstract 152 was a proof of concept trial of VH184, a third generation integrase strand transfer inhibitor. The study demonstrated that this novel third-generation inhibitor had good virologic efficacy with a significant, approximately 2 log viral decline at day 10, which is comparable to what's been observed with dolutegravir, and no evidence of resistance by either genotypic or phenotypic testing. In Abstract 153, this was a similarly designed proof-of-concept trial of a different agent, VH499, a new HIV-1 capsid inhibitor. This second study looked at this capsid inhibitor in a group of treatment-naive adults with HIV, with a primary endpoint of change in baseline HIV RNA at day 11. At all the tested doses, they did observe a substantial decline in HIV viral load of close to 2 logs. But there was one participant in the low-dose arm who had a 3.9-fold loss of susceptibility in phenotype at day 11. Finally, in this new agent development space, there was an old friend, lenacapavir, which is being studied in new formulations for yearly administration. So this is Abstract 154. They used novel formulations of lenacapavir and were able to achieve high sustained drug levels with once yearly dosing over 56 weeks. This was actually a little bit higher than the Q6-month standard formulation dosing of lenacapavir, and was still 3-fold lower than prior peak levels that have been studied for safety. So these results were simultaneously published in The Lancet and are supporting a phase 3 trial for the use of one of these formulations as once-yearly PrEP with lenacapavir. Now let's spend the last few minutes talking about some posters addressing the real-world experience with treatment with long-acting injectable therapy with cabotegravir rilpivirine. So first, Abstract 683 from the Ward 86 UCSF experience with rilpivirine. This clinic has pioneered the use of this agent in both suppressed and non-suppressed individuals and is one of the longer experiences in use of this therapy. They reported data on 437 individuals starting rilpivirine and found similar rates of discontinuation between those who had viral suppression at 6%, those with the standard FDA labeled indication, and those who had started rilpivirine with viremia at baseline, who discontinued at a rate of about 15%. In terms of when individuals discontinued, the median number of injections prior to discontinuation was 6, with 10% of the discontinuers stopping after only a single injection, and about 1/3 of the cohort of the discontinuers stopping after more than 10 injections. For those with viral suppression, the most common reason for discontinuation was pain or another side effect. And for those with viremia, virologic failure and care disengagement was the most common reason for discontinuation, but many actually did achieve viral suppression on an alternate ART. In Abstract 685, we see another data set from a large California care center at UCSD. These investigators evaluated 465 individuals who started on rilpivirine, of whom 27 transferred to care outside the system, and another 92, which was 20% of their cohort, discontinued treatment and were included in this analysis. The median number of injections prior to discontinuations in this cohort was 4, and the time on rilpivirine was about 164 days. They saw that injection site reactions and side effects were the most common drivers of discontinuation, but also documented insurance issues or difficulty in getting to clinic for multiple appointments as reasons for challenges with rilpivirine. For those patients, discontinuation was associated with a high rate of continued viral suppression in those who remained engaged back to care, and switching back to an INSTI as an oral regimen was a highly successful choice for their discontinuing individuals. In Abstract 675, we see data from the large cohort study from the Trio Health cohort of 1,198 individuals who initiated rilpivirine with follow-up between 2021 and 2024. At the end of follow-up, 79% of those people with HIV remained on rilpivirine. Overall, 89% of injections were administered on time, 69% had no delays in the cohort. There were 15 cases of viral failure, which gave a rate of about 1.6%, with a median of 7 months follow-up. And of the 8 who had additional follow-up data of those 15 cases of failure, resuppression was seen in 75% on a subsequent ART regimen. Overall, this large real-world experience is consistent with clinical trial data with a low rate of virologic failure and relatively few instances of resistance. So thank you for joining us for episode 2. Please refer to the landing page for slides and to claim your continuing education credit. Please be sure to come back tomorrow for our 3rd clinical clip from CROI 2025.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.